I'm Nuala. I'm the Sepsis ADON for CHI, and I work as part of the National Sepsis team. And I just want to kind of give you an overview of where we all fit together in the greater scheme of things. So, as you know, there's about 32, I think, national clinical programs now, one of which is sepsis. And we have a national clinical lead who, up to recently, was Martina Healy, our paediatric intensivist in Crumlin. And she was one of the key drivers for this new paediatric guideline for sepsis. And she's subsequently been replaced by Dr. Michael O'Dwyer, who's an intensivist in Vincent's. And he's literally taken on this role in the last month or so. So there are 7 sepsis ADONs, and so wherever you work, you probably know your one for each hospital group, so you'll probably know your own depending on where you work. And for CHI, it's me. And I suppose my job is really to assist in the standardization of sepsis care by developing a guideline and a national paediatric guideline for sepsis, and then the process of implementing that, and then quality assuring it as we go on. So not only the question of implementing it, but ensuring that we are auditing to make sure that it is fit for purpose and doing what we want it to do. So for the next 15 or 20 minutes, really, all I'm going to kind of cover really with you is what do we know about sepsis, what we already know, and then where are we going with sepsis? You know, how are we going to improve things going forward? So unfortunately, this is the sort of headline that we will see, and this is not separate or certainly isolated to Ireland, but it's something that we see on a regular basis. And I suppose the biggest driving force behind us trying to recognize sepsis earlier is realizing that it's an avoidable cause of death in children. And for this case and for many others, what's recognized is that the recurrent avoidable factor was the failure to recognize the severity of illness in the child. And this most often happened at the first point of contact between the sick and often febrile child and healthcare services. So whether it's GP, whether it's public health nurse, whether it's ED, it's just that failure of recognition. And so therefore, there's an onus on us to try and improve those statistics. We know that sepsis is a tricky thing insofar as it's very hard to differentiate the child who has a self-limiting infection from the child who will tip over the edge into this sepsis picture. And it is exactly like a domino effect insofar as if we don't identify at the early stages down here at the infection stage that there's a problem, and we get this uncontrolled immune response, we really need to put on the brakes before we get this cascade of inflammation, coagulation, hypovolemia, and organ failure. So given that is the trajectory of sepsis, we need to identify where we can intervene and at what point, and how early on we can try and identify this disease. Also, the epidemiology of pediatric sepsis changed in the last 10 years or so with the advent of effective vaccines. So given my age and how long I'm nursing, I would have historically have met children who were septic due to Hib or due to meningococcal B or C. And now with the advent of these vaccines, that has really changed the pattern of PICU admissions, albeit that we still may, we need to keep in mind all the time that we could have instances where the vaccine has failed in certain children, and certainly there may be instances where the vaccine hasn't been taken up by children. But generally speaking, vaccines have made a huge difference in what we see presenting as sepsis cases. And what we see primarily is our high-risk kids that present with infection and progress to sepsis. And these are, no huge surprise to anybody who works with children. We're worried about the little small ones, less than a year, less than 3 months, low birth weight infants who have no significant immune systems to start with. Any child with an injury or with a wound or surgical incision are more prone, obviously, to infection and therefore sepsis. Any child with a chronic debilitating medical condition. So again, our cohort of chronic illness, we need to just have a very low threshold for these kids if they develop an infection, that we need to be really keeping our eyes on these kids. if they have immunosuppression, whether that's due to disease, like a malignancy, or whether they're actually taking medication, as you know, that causes that immunosuppression. We know that these kids are far more likely to develop sepsis. So we need to kind of be aware of our risk groups and to be screening for those a little bit maybe sooner, so that we can catch these early. I suppose it's all about good catching early is what we're trying to achieve. And we know that our global burden of sepsis is significant. And this statistic is from the Lancet article in 2018, looking at the incidence of pediatric and neonatal sepsis. So looking at those figures, if you think of a large pediatric emergency department that sees 50,000 patients a year, and that would probably be on average what comes through Tempest Street and Crumlin's doors, they will see one sepsis a week. 50% of them are newborns. So there's a high statistic there. And our mortality rate is high from that. So we need to do a couple of things. We need to ensure that we're educating at healthcare professional level, but we also need to improve our public awareness campaign so that children present a bit sooner to us. So that's kind of where we're at, what sepsis is to us currently, but we need to kind of look at where we are now and where we're going and how we're going to improve things. So just to give you a little bit of background, the National Sepsis Programme updated the adult national guidelines back in 2020, and they adopted the 2016 Surviving Sepsis Campaign international guidelines in their entirety. But paediatrics weren't included, and that is often the case. We find with paediatric guidelines, as we know, anybody who works in children, often, you know, what happens is there's an adult guideline produced, and then as a paediatric cohort, people who work with children, we look at bits of it, we grab bits of it, and we decide what that'll do, and we can work with that, and we can work with that, and we kind of cobble together our own guideline. But you know, we'd like to work off an international standard of care. And so thankfully back in 2020, then last year, the Surviving Sepsis Campaign produced international guidelines for the management of septic shock and sepsis-associated organ dysfunction in children. And as a result, the sepsis programme convened a multidisciplinary paediatric sepsis working group to, number one, look at those guidelines and see are they fit for purpose, and then to see how we would adopt that within an Irish context. So looking at the guidelines, and we're, you know, it's quite a broad guideline. It's an international guideline, so we're dealing with first world countries, third world countries, and everything in between. We needed to, the recommendation was we adopted these guidelines in their entirety, but we needed to write some implementation points that were relevant to the healthcare setting in Ireland. So we sought permission for the Surviving Sepsis Campaign, and we produced a national implementation to support the implementation of these guidelines across the healthcare setting in Ireland. We distributed this implementation plan for consultation, and we got it externally reviewed by the chair of the Paediatric Surviving Sepsis Campaign. And then we got it clinically approved, thankfully, in August of this year. And so as a result, it'll accompany the National Clinical Guideline for Sepsis to ensure that we have a unified approach to sepsis management across all age cohorts. So that's where we're at the moment. So that was launched in September of this year, and so the next big job ahead of us is to implement it. So this is what it looks like. It's on the sepsis website, and we are running an implementation program in early 2022, but it contains 77 recommendations, and you know, it's focusing in on septic shock and sepsis associated organ dysfunction. And we have implementation points then to assist clinicians, and nurses are clinicians, just for clarity, in the management of paediatric sepsis in an Irish healthcare setting. Part of the implementation plan was to ensure that we had some sort of sepsis tool that would assist us to screen, recognise and treat sepsis in a timely manner. So I'm going to just give you the kind of the big ticket items that are resulting from this Surviving Sepsis Guideline publication. Now I just want to kind of highlight this because these guidelines are specifically dealing with septic shock and sepsis associated organ dysfunction, but The panel of experts that wrote these guidelines recognized that sepsis is a spectrum, and some children without known acute organ failure will still benefit from therapies as those who would have organ dysfunction. So the child who presents with an infection, it's very hard with sepsis, with infection, and progressing to sepsis. It's a spectrum of disease. So it's very hard to know in an undifferentiated child that presents to the emergency department whether or not this child could potentially be septic. So it's really about best practice, and then for each country and each hospital to adapt a guideline that is suitable for their cohort of patients. So one of the strong recommendations was that we implement a screening for the timely recognition of septic shock and other sepsis-associated organ dysfunction. And I suppose sepsis screening is driven by the premise that early recognition will lead to more timely identification of sepsis, and therefore we'll initiate therapy earlier, and we will reduce morbidity and mortality. So that's the premise behind screening early. And so we felt very strongly that we needed a very good clinical decision support tool to assist people in screening, recognizing, and treating within a time frame. The other strong recommendation was to implement a protocol, which, as I say, we've just published in the last month or so. Another big ticket item, and this is a no-brainer really, for children who present with septic shock, the recommendation is we start antimicrobial therapy as soon as possible within 1 hour of recognition. And this is our 1 hour sepsis bundle. And this is a no-brainer. If we've got a child who presents obtunded and septic shock, we need to treat them immediately. However, in a child with sepsis-associated organ dysfunction but without shock, there was a wider time frame allowed to start treatment, and this was a real game changer when it came to children's health, if you like, because prior to this we were looking at the adult guideline of you must start your sepsis bundle within an hour, and there was a reticence from the pediatric community saying, look, this child could be viral, we don't keep giving antibiotics to these kids unnecessarily, we're going to cause problems down the line with drug resistance later on for these kids. We need to be able to be sure that what we're dealing with is potentially sepsis, and sometimes we can't do that within the hour. So if the child is not shocked, we need to spend a little bit more time doing further investigations, getting a good full clinical examination, getting some more laboratory tests to help us decide whether or not this child has the potential to be septic or not, and therefore subsequently treat them. So that has made a huge difference from the point of view of our treatment. The suggestion was that crystalloids were more suitable than albumin, and certainly balanced buffered crystalloids were preferential rather than 9% saline. And that's a big difference to what we would have routinely practiced in the past. So this idea that we would always have advocated, we give, our bolus of saline followed by a bolus of saline followed by a bolus of saline. And what the research is showing us is that we keep bolusing with saline over a period of time will make that child more acidotic and more hyperchloremic. So there's a bit of a pull away from treating children with sepsis with just saline, because you're just giving them salt on top of salt on top of salt. Whereas if you give them a balanced crystalloid like Hartmann's, it's more electrolyte friendly and certainly more plasma-like, if you like. So that's not to say, because I immediately can hear people screaming at me saying, but we always give normal saline. And in the first instance, if a child presents to you in the emergency department and you need to give them a bolus of fluid, it's reasonable to give them saline as a first bolus. But if we're dealing with a child who is potentially septic and we are bolusing and they're fluid refractory, we need to stop and think, at this point, we may need to move them on to balanced crystalloids in preference. Another strong recommendation was to take blood cultures. Again, nothing that we don't already know, but don't delay treatment to obtain them. And this is really in the background of a child who is small, or a young infant who presents to the emergency department, who is very obtunded, who we find very difficult to get blood on in the first instance. And we know we need at least 1 ml of blood for a blood culture. So we don't want, if this child needs to be treated, we want you to treat with antibiotics, and don't delay treatment because you didn't get a culture. But preference would be to get a culture in the first instance. We'll treat with broad spectrum antibiotics, but we'll narrow when we identify the pathogens. And again, that's following our guideline of start smart and then focus in on our pathogen once we identify it. And then there were recommendations regarding vasoactive medication and ventilation. And again, they were based on weak recommendations insofar as it depended on your availability and your accessibility to intensive care support. So this is the sepsis form. The front page is our screening and recognition, and our back page is treatment and referral and reassessment. And it enables us to escalate care maybe a bit more timely, because what we have found and what we do know is that our pediatric early warning score is capturing deterioration, but in the background of sepsis, we find that our early warning scores are low. These kids don't have high scores of 7 and above and eliciting a puke call. These kids are often bouncing around on a score of 3 or 4, and if we treat the score and not the child, this is where we have a problem. And when we look back over sepsis cases, and we look back over children who've presented with sepsis and who ended up being admitted to a PICU, and we look back over their observations and their early warning scores, what we found was consistent was that they had a persistent tachycardia that wasn't responding to, irrespective of them having a temperature or irrespective of I suppose, an appropriate tachycardia. These kids were bouncing along, scoring a 1 on an early warning score. And also the other kind of cardinal early vital sign was this, not necessarily not alert, but these kids were withdrawn, less themselves, less interactive, and parents were picking up on that very early on. But yet our early warning scores weren't high, because children have the ability to compensate. So they would bob along with just this low-grade tachycardia, and then they'll fall off the cliff. So we just need to be looking out for that a bit earlier. So the premise of when we want to pick up the sepsis form is if there's a clinical suspicion of infection and the child appears unwell, then we want the question asked, could this be sepsis? So we are advocating for both nurses and doctors and any healthcare professional who is treating a child, who reviews a child or goes in and sees this kid in the bed who's looking just a little bit more miserable. They may have a temperature, they may be a little bit tachycardic, they're a little bit off form, that we're just thinking about early on, does this child require screening for sepsis? And it's about your own clinical judgment and your ability to identify the child that is unwell in themselves. And we screen then for sepsis. So we're looking for red flags, which are very obvious signs that this child is under pressure. And if they have a red flag, that's an immediate medical review. Or they may have more subtle signs in the early stages, and they may have no red flag, but they certainly may have an amber flag, which are a bit more nuanced flags insofar as we're reliant on parental concern as one of our early flags. And we have learned to our peril that if we ignore parents, our outcomes are never so good, because they are usually very susceptible to subtle changes in their child's condition. So we need to look at our amber flags, and we need to then consider our risk factors additionally. And depending on whether they have amber flags or indeed red flags, the clinician is called to review this child, and based on that review will dictate whether or not this child needs to be treated for sepsis or not. And if the treatment is required, we will treat them with the sepsis fix bundle. And I'm not going to go through that. You know that. It's take 3, give 3. It hasn't changed. And then we reassess. And I think what's very useful about this form is that it actually gives us a definitive way of identifying sepsis. Whereas up to now, sepsis has always been this, it could be sepsis, it might be sepsis. It's a kind of a differential diagnosis. We never kind of get a definitive diagnosis of sepsis. So if we deliver our sepsis fix bundle and we reassess, we're looking for signs of new organ dysfunction. We're looking at organs in isolation and taking additional blood tests or additional screening, and any new organ dysfunction due to infection is sepsis. So sepsis is infection plus organ dysfunction. And if we have an identification of that, then that child is septic and then therefore requires a higher level of care. We need our consultant pediatricians involved in their care, and we need an early conversation with PICU to get some advice, support, and potentially, depending on where you work, transfer this child to a PICU. And that's important. So Implementation will happen in January. We're just finalising the interim education material. We're also piloting the sepsis form currently across CHI in both the emergency departments and across wards to make sure that it is fit for purpose and to tweak out any problems before we go national. So the intention will be from January is for us to implement the paediatric sepsis guideline across all paediatric sites. And how that will happen is in conjunction with our national sepsis team, and our sepsis ADON will support. We need local sepsis committees on each hospital, or a deterioration patient committee. We're finding a lot of the time now, PEWS and sepsis and deterioration are all kind of coming under one umbrella. So a deterioration patient committee to drive this guideline is what is required, and identification of local nurse and medical leads to help drive the guideline forward and to ensure that we're screening and doing what needs to be done. So support will be from myself personally. I'll be going around helping my own sepsis ADONs on the team and supporting as best I can nationally. We want to standardise education material. So as I say, we've interim material more or less ready to go. And we've just started on an e-learning programme for sepsis, for paediatric sepsis on HSE land, which will be ready in June 2022. And then we need and require that our deterioration patient committee takes ownership of this guideline and drives it forward. And then obviously one of our key triggers and targets we need to ensure is that the public are aware of sepsis in children, that it's not that we're getting that education out there. So by using social media cuts, we've done a lot of work on videos and social media cuts, leaflets and sepsis awareness days, but it's a bit like, it's a bit like our road traffic accident videos that we see on the news. It's something that we need to keep driving every couple of months, because if we just do one big launch and leave it, then people forget. So it's something that needs to be persistently driven over time. And that's me. That's me done.